Substance-related and addictive disorders, Part 3. Chemically impaired nurses. The estimation is 10 to 15% of nurses suffer from chemical dependency. Alcohol is the most widely abused drug, followed closely by narcotics. High absenteeism is present when they have to seek the drug at a location outside of their workplace. However, when they are using a substance from work, then they rarely ever miss work. So I do want to tell you about a story. I had employees when I was ADON. I had nurses that were actually stealing narcotics, and they had to be reported to the state. Um, so oftentimes the state will put them on probation and give them a plan of correction, so they cannot have access to narcotics and things of that nature. However, they were terminated from our facility. Nevertheless, it does occur. So when you are doing your NARC count, make sure you are counting each and every time, even if it's your best friend that you're receiving the keys from, because if the medication is missing on your shift, it's going to be your fault. Increase in wasting of drugs. These are some of the behaviors that happen. Higher incidence of incorrect drug counts. Higher records of signing out drugs for other nurses may be present. Poor concentration, difficulty meeting deadlines, inappropriate responses, poor memory or recall, problems with relationships, irritability, tendency to isolate, elaborate excuses for behavior. And sometimes these individuals will give medication, prescribe narcotics, will be signed out for people who don't typically take their narcotics routinely, or at times they don't routinely take them. So when you start working as a nurse, you'll know Mrs. Smith always takes her pain medication at 8 p.m., but she never takes it during the daytime, right? So then you'll have this nurse that comes along and she's giving it like every 4 hours or every 6 hours, around the clock, and that's not the normal behavior. So this is just some telltale signs that you might need to um, speak with a supervisor or someone in authority and let them do some type of investigation. Or another behavior is they will give the patient Tylenol and say, "Oh, I gave them a Percocet," but they took the Percocet, right? So they will give like a placebo and not actually what the patient believes they're receiving. So the parents may be unkept. They may have impaired motor coordination, slurred speech, flushed face. Patients may complain of inadequate pain control or discrepancies in documentation. So that's what I was mentioning earlier. If a report is made to the State Board of Nursing, the board must deny, suspend, or revoke a license. So when I mentioned probation, that's the suspension part, I believe. Several state boards of nursing have passed the divisionary laws that allow impaired nurses to avoid discipline by agreeing to seek treatment. Okay, maybe that's what I was speaking of. So they seek treatment and get put on probation and monitored. Some of the state boards administer the treatment programs themselves, and others refer the nurses to community resources or state nurse association assisted programs. During the suspension period, successful completion of an inpatient, outpatient group or individual counseling treatment program, evidence of regular attendance at nurse support groups or at 12-step programs, random negative drug testing, employment, or volunteer activities. Peer assistance programs serve to assist impaired nurses to recognize their impairment, obtain necessary treatment, regain accountability within their profession. Codependency is defined as the functional behavior that are evident among members of the family of a chemically dependent person or among family members who harbor secrets of physical or emotional abuse, other cruelties, and pathological conditions. Codependent people sacrifice their own needs for the fulfillment of others to achieve a sense of control. Derives from self-worth, derives their self-worth from others, feels responsible for the happiness of others, commonly denies that problems exist. Keeping feelings in control often releases anxiety in the form of stress-related illnesses or compulsive behaviors such as eating, spending, working, use of substance. Classic characteristics of the codependent nurse. So they're caretaker, they are perfectionists, they're in denial, they have poor communication skills. So treating codependency, the recovery process is 4 stages. The first stage, which is the survival stage, is letting go of the denial that the problem does not exist. So this stage is very emotional and painful sometimes. Then you have stage 2, re-identification stage. So as you start to let go of the denial, you start to see your true self and realize that you do have dysfunctional behaviors and you do have limitations and you're facing them head on. Stage 3, the core issues stage. At this stage of recovery, the codependent must face the fact that relationships cannot be managed by force of will. Each partner must be independent and autonomous. The goal of this stage is to detach from the struggles of life that exist because of pride and willful effort to control things. Then you have your stage 4, which is reintegration stage. This is the stage of self acceptance, willingness to change, when codependents relinquish the power over to others that will not rightfully that's not rightfully theirs, but reclaim their own personal power that they do possess. Okay, so you realize that you're in control of yourself at this stage, right? You're reclaiming your own personal power and you're not trying to control or manipulate others. Alcoholics Anonymous. So this is a support group, a major self-help organization for treatment of alcoholism based on the concept of peer support, acceptance, understanding from others who have experienced the same problems. The 12-step program that embodies the philosophy of AA or Alcoholic Anonymous provides specific guidelines on how to attain and maintain sobriety. Total abstinence is promoted as the only cure. The person can never safely return to social drinking. Treatment modalities for substance related disorders. Various support groups patterned after AA, but individuals with problems with other substances. So they may have NA, Narcotics Anonymous. So I don't know them all, but there's other support groups. So your book has a table 14-11, and it does mention the different support groups. They even have support groups for families of the person that's struggling with addiction. Then counseling. So counseling can be one-on-one basis to help the client who abuses a substance, or you can have group counseling or group therapy. Pharmacotherapy for alcoholism. So we have anti-abuse, and anti-abuse is a drug that can be administered as a deterrent to drinking to individuals who abuse alcohol. And for our withdrawal symptoms, there are several drugs that we use to manage them. So if you remember, the alcoholic usually has that low B vitamin, but the thiamine level is very low, which can cause psychosis. So they are given benzodiazepines, anti-convulsant drugs. So these are to help with the withdrawal symptoms, and multivitamins and thiamine because they are usually not eating well because they're so consumed with drinking, and they are losing weight and really are generally not healthy. Psychopharmacological for substance intoxication and substance withdrawal. So some other medications we have is Revia. Revia is a narcotic antagonist. So the FDA approved this in 1994 for treatment of alcohol addiction, and it's been approved since 1984 for treatment of heroin abuse. We also have Revex, our SSRI drugs, which are antidepressants, selective serotonin reuptake inhibitors, and these drugs decrease the alcohol craving among alcohol dependent individuals. And we also have Capril, which was approved by the FDA in 2004. And this was approved to help maintain abstinence from alcohol for our clients struggling with alcoholism. So for our opioids, we have our narcotic antagonists, and that's Narcan, Revia, Revex. Then we have our buprenorphine, and this is less powerful than methadone, but it is considered to be safer than methadone. It has fewer side effects. Then we have clonidine, also known as Catapres, which is used to suppress opioid withdrawal symptoms. So this is typically a blood pressure medication, but it is used um, for withdrawal symptoms as well. We have our depressant drugs. So our phenobarbital, which is the most commonly used long-acting barbiturate for signs of withdrawal, and this is a CNS depressant. Then we have our long-acting benzodiazepine, and so the long-acting benzodiazepine are commonly used for substitution therapy when abuse of the substance is a non-barbiturate CNS depressant. Next, we have our stimulant drugs. So we have our minor tranquilizers, our major tranquilizers, our anticonvulsant drugs. So seizure medication is used sometimes for withdrawal symptoms, and our antidepressant drugs. As we spoke of, the SSRIs are often used for treatment of withdrawal symptoms as well. So we have our hallucinogens and cannabinoids. So benzodiazepines and antipsychotics fall under this category. Substitution therapy is not required for these drugs, but when adverse reactions such as anxiety or panic occurs, benzodiazepines may be prescribed to prevent harm to others as well as to their client. And psychotic reactions may be treated with the antipsychotic medications. Gambling disorder is defined by PSM-5 as a persistent, recurring, problematic gambling behavior leading to clinically significant impairment or distress. The impulse to gamble often intensifies when the individual is under stress and may describe a physical sensation of restlessness and anticipation that can only be relieved by placing a bet. Gambling behavior usually begins in adolescence through compulsive behaviors, rarely occurs before young adulthood. The disorder usually runs a chronic course with periods of waxing and waning. The disorder interferes with interpersonal, social relationships, academics, and occupational functioning. Predisposition for gambling disorders. So they believe there may be a biological influence, so genetics increase the incidence among family members, and a physiological abnormality of neurotransmitter systems. Predisposition factors for gambling disorders, psychosocial influences, loss of a parent before the age of 15, inappropriate parental discipline, exposure to gambling activities as an adolescent, family emphasis on material and financial symbols, lack of family emphasis on saving, planning, and budgeting. Treatment modalities for gambling disorder. So for our psychopharmacological, we have our carbamazepine, naltrexone, lithium, clomipirine, and SSRIs, which are antidepressants. Then we also have behavioral therapy, cognitive therapy, and motivational interviewing. So they do have a Gamblers Anonymous, very similar to our Alcohol Anonymous or AA. The only requirement for membership is the desire to stop gambling. Reformed gamblers help others resist the urge to gamble. So Gamblers Anonymous is known as GA.